Right, okay, so my name is Rasmus Strandmark. I present myself earlier, but I'm an emergency physician, Swedish origin, trained in Sweden, but currently working in Reykjavik, Iceland. I am also a PhD student at the Háskóli Íslands, as I said. Now we'll talk about one of the oldest drugs that we still use, nitroglycerin, and why we should feel very confident in administering this generously to patients with sympathetic crashing acute pulmonary edema, or SCAPE. I have no conflicts of interest here. Nitroglycerin has been around since 1847, and it was first used to treat angina in 1879. At low doses, it primarily affects the venous capacitance and decreasing preload, which then lessens the workload of the heart. At higher doses, nitroglycerin decreases afterload, which is the effect that we're looking for in hypertensive emergencies. It can also dilate coronary arteries, which can be beneficial in conditions like coronary artery occlusion and vasospastic angina. Sympathetic crashing acute pulmonary edema, or SCAPE, also sometimes called flash pulmonary edema, is a specific subset of acute heart failure involving a surge of catecholamines causing severe systolic hypertension with rapidly worsening pulmonary congestion. The typical SCAPE patient experiences a fairly rapid and sudden onset of dyspnea, diaphoresis, feeling of panic, impending doom, and clinically they present typically eovolemic, not overly with overfluid load, and desaturation, tachycardia, and diaphoresis, and then obviously B lines on their lung ultrasound. In the Nordic setting, these patients have become less common nowadays, because obviously people with hypertension are quite well medicated in our setting. But it's important to be able to recognize this state, as these patients need immediate intervention to keep them from spiraling into cardiac arrest. The cornerstone treatment in SCAPE is high-dose nitroglycerin, often combined with CPAP or BiPAP. And unlike treating chest pain or ordinary congestive heart failure, where it's enough to decrease preload only, in SCAPE it's required a really high dose nitroglycerin. Vasoconstriction is more prominent, and this results in increased afterload, and then these high dose nitroglycerin comes into play to introduce arterial vasodilation and decrease blood pressure. So therefore, every emergency musician is a good word as well, but physician should be able to administer these high doses and completely comfortable with doing that. Let's look at safety for nitroglycerin initially here. There's always a bunch of contraindications stated for all the medication that we give, and allergy is most of the time one of them. In nitroglycerin, this is very rare. There's only one case in the literature of an anaphylactic reaction to intravenous nitroglycerin, so we could feel safe in this aspect. A common one mentioned is also the use of Viagra or other phosphodiesterase inhibitors. According to recent studies, the interaction between these two drugs to produce excessive hypotension diminishes greatly at 12 hours, not the 24 hours previously noticed. So after 12 hours, the interaction is minimal. In shorter time frames, dose adjusting is prudent, but using a phosphodiesterase inhibitor is not a contraindication to nitroglycerin, but you do sometimes have to dose adjust. Right coronary infarction have long been thought to be a contraindication, as the cardiac output of these patients, at least theoretically, would be more preload dependent. A meta-analysis including 1,113 patients did not find this to be clinically relevant. There was another 60 patients in a study not included in this meta-analysis that also did not report any significant increase in hypotension or other adverse events. Aortic stenosis mandates caution, but in the presence of SCAPE, it's not a contraindication. And then finally, hypotension. There are no specific studies on this, but there are a few cases mentioned in the literature of hypotensive patients receiving nitroglycerin. In this study, for instance, they were given 1 and 2 milligrams bolus of nitroglycerin with low blood pressure, and the outcome was okay. There was no additional drop in blood pressure in those cases. This is a list of all the studies that report adverse events for patients receiving nitroglycerin pre-hospitally or in the ED in the last 34 years, since 1990. I have not included case reports here, so we'll mention a few of those later. Across all of these studies, involving almost 96,000 patients, hypertension was the most common side effect, occurring in 2% of the cases. The vast majority of these were mild and transient, some resolved spontaneously, and some received a small fluid bolus. One interesting thing is this study also included patients not receiving nitroglycerin, so they were able to compare the two groups, the ones that did get nitroglycerin and the ones that didn't. And what they observed was that there was no statistically significant difference in hypotension between these two groups. It would have been really interesting if more studies looked at this, because judging from that, it is not entirely impossible that transient hypotension is part of the pathophysiology in people with myocardial infarction or pulmonary edema, rather than it being a side effect of nitroglycerin. Nitroglycerin is also known to cause reflex tachycardia. So in this study, there was a lot of adverse events, as they said that a pulse over 120 was an adverse event. It can also cause bradycardia, but is much less common. Among all 95,817 patients, there was only 2 documented cases of loss of consciousness. One was a syncope with unknown heart rhythm, and the other one was an asystole lasting for 2 minutes with subsequent ROSC. In the 2 largest studies, the details around cases listed as altered state of consciousness aren't further defined. In Pro's study, there were 30 pre-hospital cardiac arrests. 3 of them did not have ROSC before arrival at hospital. There's also 1 case report that's not on the list, with a patient going into VF shortly after receiving a dose of sublingual nitroglycerin with subsequent ROSC after 1 defibrillation. Obviously, these patients are all patients with unstable angina, myocardial infarction, or pulmonary edema, so the authors don't expect any causality here. I've been able to find 6 published cases of transient asystole following nitroglycerin dispensation since 1990. As you can see, one of these cases, or only one I should say, is a subject from the previous studies. So this could imply a prevalence of 1 in 100,000 for this event. It seems to be extremely rare, at least. All the described cases had ROSC spontaneously or after a brief period of chest compressions. And atropine was sometimes added for a consistent bradycardia afterwards. And there's no documented cases of nitroglycerin causing death when administered by healthcare professionals. So now that we feel reassured that nitroglycerin has an excellent safety profile, we can move on to the studies that are looking at high-dose nitroglycerin for treatment of SCAPE. And this is that list. and the number 791 refers to the patients that actually had high-dose nitroglycerin. There was some additional patients in some of the studies in control groups. I generally consider 1 milligram of bolus or 400 micrograms per minute to be high dose, but I did include 2 studies, the Hausman and Kelly studies here, that didn't give that higher dose. Only sort of to illustrate how important it is to push the doses up. In these studies, they gave 100 to 200 micrograms per minute and didn't have much effect of that. The Cotter and Sharon studies from the late 1990s are quite interesting because they both report a decreased mortality rate. And this is mostly reflective of how severe the cases were back then. In newer, more modern studies, the positive outcomes are most of the time decreased need for intubation, less ICU admission, shorter length of stay in the hospital, and some patients actually getting discharged from the ED and not getting admitted at all after treatment. The largest recorded bolus dose ever given, as I can find in the literature, was in the Giori case report. They had to repeatedly give doses of up to 16 milligrams at a time to turn a really severe escape around. They administered a total of 56 milligrams in a very short time frame without having any adverse events, one might add. In these studies, there were no cases of methemoglobinemia. There are case reports from the 1980s when nitroglycerin was used more excessively, that this might happen with prolonged exposure or high exposure, but it seems not to be such a big problem with a lot of a high dose in a short time frame. So nitroglycerin is remarkably safe. Even at high doses, it seems to be extremely difficult to harm a supine patient while administering significantly large doses of nitroglycerin. The greatest risk that we have is underdosing in SCAPE. The evidence is there to support the use of aggressive nitroglycerin dosing in this context, and it seems almost impossible to induce harm, right? In fact, there are more cases described of nitroglycerin bringing patients back to life than actually killing them. So I want to share 2 of those cases with you here. The first case is about a 70-year-old man brought to the emergency department with an ambulance after being found unresponsive. First recorded rhythm was a PEA, and he had 3 rounds of CPR before converting into ventricular fibrillation, getting defibrillated into a sinus. He had had a non-STEMI recently with normal angiography, a normal echo, and he was known to use tobacco and cocaine. Initial ECG in the ECG showed inferior ST elevations, so he was brought to the cath lab, and there they saw a left main stem stenosis, which didn't make any sense given that he recently had a normal angiography. So they figured it could be a cocaine and possibly adrenaline-triggered vasospasm. So he got intracoronary nitroglycerin and the vasospasm resolved. On the day 3 of hospitalization, the patient abruptly became hypotensive and developed pulseless ventricular tachycardia. They thought that it might be a new vasospasm, so despite the patient being hemodynamically unstable with low blood pressure, the decision was made to administer 500 micrograms boluses of nitroglycerin. The ST elevations gradually resolved, and the patient regained a pulse with repeated boluses. He was discharged, had a memory loss of the event, but otherwise he was back at baseline on follow-up visit 3 months later. The next case is a 86-year-old male with prior history of coronary artery disease that had a sudden onset chest pain and then collapsed in the hospital waiting area. He had VT, got defibrillated, given 300 milligrams of amiodarone. He had a brief episode of sinus rhythm and then another 16 minutes of VT-VF before getting ROSC again. After 15 minutes, he went back into rest, and they did CPR for a continuous 50 minutes before he was in asystole. At that stage, they gave him 4 milligrams of IV nitroglycerin. They did another 3 minutes of CPR before giving up and pronouncing him dead. However, 2 minutes later, the nurse noticed that the patient was breathing, had normal sinus pulse with a palpable pulse, and blood pressure of 137/58. He was diagnosed with myocardial infarction, extubated on day 2, discharged with full neurological recovery on day 18. Obviously, these cases, at least the second one, is absurd, so I'm not recommending anyone to give nitroglycerin to a cardiac arrest after this lecture. But the authors of the last case report seems to have been doing just that. These are all the previous cases that they had, patients with cardiogenic shock, severe pulmonary edema, and they administered nitroglycerin despite hypotension. In these cases, nitroglycerin increased blood pressure instead of lowering it. It's an interesting hypothesis that if you have an escape patient in front of you and the patient crashes, it might not be that you should straight away go into the ALS algorithm. It might be that they still benefit from nitroglycerin despite being in cardiac arrest almost or crashing in front of you. Speculative, of course. What's perhaps less speculative is the notion that nitrous oxide, the active component of nitroglycerin, might not be capable of inducing life-threatening hypotension, regardless of circumstances or doses. And what should be definitely clear to all, looking at all the millions of patients that receive nitroglycerin each year and adverse events being exceedingly rare, is that giving patients nitroglycerin in the doses required is safe. That's really sort of the end of my talk on high-dose nitroglycerin. But before we start the discussion or take out any questions that might have popped up, I would like to talk to you about 2 studies that predominantly uses or looked into low doses of nitroglycerin pre-hospitally. The first study is my own. We included 1,726 patients in the emergency, in the ambulances in Gothenburg with a final diagnosis of myocardial infarction. We investigated pre-hospital treatment given to these patients and found that if the patient had received nitroglycerin pre-hospitally, they had a greater chance of being alive 1 year later, even after adjusting for confounders. Obviously, this is retrospective data, so this is an association, not a causation. But then this study showed up a few years ago, really interesting study looking at decompensated acute heart failure patients receiving intravenous nitroglycerin. Spanish study, 292 patients received intravenous nitroglycerin pre-hospitally. And they were obviously then more severely decompensated than the patients that did not have this treatment pre-hospitally. Despite this, they had lower mortality at all points of measurement, including 1 year after the event, when compared to both patients that only received nitroglycerin on arrival in the ED or having the nitroglycerin started in the ward later. So if there's anyone out here in the audience that really wants to find an RCT to do, I am super interested to see if there's any causality between really early nitroglycerin and survival in these patients. Thanks a lot. Is there any, sure. Is there any questions? Jonas?
Is it on? Yeah, right. So I've treated quite a lot of these escape patients, and I've personally never been have to use more than like 400 micrograms, 4 to 5 puffs. Yeah. And then I go to IV. So I've never seen the need for this, but obviously I've read the studies and seen all the, listened to the podcast and stuff. Like, how often do you actually need to go up to those levels?
Yeah, it's a good question. I mean, as I said, in our setting, it's quite rare nowadays, and most patients come in quite early. So we are able to turn them around most of the time just using sublingual nitroglycerin, or sometimes just a couple of minutes with IV doses, 1 milligram at a time or something like that, or 400 micrograms running for a couple of minutes. Most clinicians also add the BiPAP, getting a bit of effect from that as well. So yeah, I agree. Most of the cases, if you realize what's going on, you're able to turn it around early in our settings. I've had a case, it's a few weeks ago now, but I had 2 cases this year. And the last case, I had to use 4 milligrams repeated doses and coming up to 21 milligrams. But yeah, it's quite rare, still life-threatening. So, yeah.
Hello, do you hear me?
Yep.
Igor Olinik, Danderitz Hospital. I have a question about how do you control blood pressure? Is it usual non-invasive blood pressure control, or you prefer to control like with arterial line? Because it can be difficult to manage like the proper level of the blood pressure.
Yeah.
If you use intravenous.
Right, yeah.
Yes.
So, I mean, the nature of the situation when the patient comes in, when this is really sort of a true emergency, I don't regularly put up an art line for these patients. I start treatment straight away, so I largely rely on the clinical picture, obviously, but also just the non-invasive blood pressure measurement. I try to be very aggressive initially instead of trying to sort of chase the situation and under-treating initially. I just give them a very large bolus dose initially and see if I can get that blood pressure down. But yeah, to answer your question, it's absolutely the non-invasive blood pressure that I usually use. The time of the treatment is also limited. If you're really aggressive initially, this is over within 10-15 minutes. So, yeah.
Hi, Nermin from Karolinska. I'm thinking about if I can see there is underlying hypovolemia. Is it like better to start infusion than giving intravenous directly?
Right. Yeah, so in my experience, they're eovolemic. They're just sort of not hypervolemic or decompensated in another way. So I have never started any infusion on this patient, but to touch on it, it's really a distribution issue. So it might be that the two situations occur at the same time. You have a dehydrated patient with pulmonary edema. Haven't seen that, but theoretically possible. And what nitroglycerin do is just to redistribute the fluid from the lungs to the rest of the circulation. So yeah, you could absolutely use nitroglycerin in the setting that you're talking about, I think, even though it would be uncommon. Mm-hmm. Yeah. That's great. Okay, so is there anyone that feels completely confident in using this? Jonas was using this a lot, or is it something that's not really part of your practice? It's not sort of standard practice. And I appreciate it because it's not very often we see this. But as I said, when you have the rare occasion of these, and I mean, we have tourists and we have people not really taking care of their health. So it does happen occasionally, and it's important to be able to feel confident in giving the doses, because it's a bit counterintuitive to smash the patient with these large intravenous doses of undiluted nitroglycerin. Most nurses would say, no, can we please put up the drip with 5 to 10 micrograms per minute instead and just start from there? And that's not the right tactics in this instance. You have to be very aggressive initially. And as I hope I've been able to show, it's really safe to do that. You're not going to crash the patient. Contrary to that, you'll save the patient if you're able to do this initially and bring the patient down. An additional question? Let's just get the microphone for you. Great.
But a quick question would be that it sounds like you think it's superior to any other treatment for escape.
It'll be interesting to hear what the alternatives would be.
No, I mean, most of the times I think we go for, you know, some kind of CPAP, BiPAP, potentially diuretics as well because it's an edema problem. I do use puffs often, but then it's another adjunct.
Yeah.
But this sounds more like a definitive treatment.
Yeah, so interesting. I mean, most clinicians would probably incorporate both at the same time, but using only BiPAP will take significantly longer. You'll have the patient on hours on the BiPAP. It's really not the correct treatment, but I always use, not always, okay, but most of the time I use BiPAP as well, especially with these mixed patients that do have some component of a normal sort of looking congestive heart failure with a bit of fluid overload. It's very sort of good to get the blood pressure down with the initial nitroglycerin. During those few minutes, they'll set up the BiPAP and we'll have the patient on that for a few hours. But a really true isolated escape patient would theoretically just need nitroglycerin. But yeah, to answer your question, I use BiPAP as well, but not solely. I always incorporate nitroglycerin. Another question there? Do we still have time? Okay, final question.
So if you have a hypo or normal tensive patient that you think has escape, because they can have, do you have a level where you don't start with nitroglycerin and just go for CPAP first?
Right, yeah, because it feels a bit uncomfortable, even to me, to give someone with a blood pressure under 100 nitroglycerin, right? It just feels uncomfortable. So I dose titrate, but I've done it on several occasions and it doesn't happen anything. Sadly, the pulmonary edema doesn't really react as well either, but it seems to be safe in the small amount of patients that I've done it for. Yeah, the indication might not be there. But if you find a patient that you think might benefit from nitroglycerin despite hypotension, then it's safe to do it in small increments and just see what happens. All right. Thanks a lot. Right.